That was the highest joint we had, so let's start there. Supine. The way we mobilize OA, and we tend to mobilize OA versus thrust OA simply because it's an area that is very prone to legitimate mobility restrictions. And we find that non-thrust mobilization addresses that better than thrust manipulation. So it's an area that we tend to sink into with our body weight over a long period of time. The key is don't have the pillow under the shoulders. Otherwise the patient's back in extension, you're not helping yourself out of the gate. So make sure that's outside of the shoulders and you're in this position. Don't even be afraid to help yourself out a little bit by bringing them up into suboccipital nod out of the gates. Your thumbs, zygomatic arch. Forehead, your chest. Two methods, right? The first one is straightening out your front knee to nod the head and then bending both knees to retract the neck. So we're here, forehead, okay? Straighten out my front knee and nod, sink down and retract. Option number one. Option number two, probably more common, is to use your hand on the forehead. So now we're here. My underside hand can feel the suboccipitals lengthening. My overside hand goes around the eye. Now I can rotate her a bit towards the left because I want to drive into that left OA. Now I'm up above her, and never forget, it is my front knee always doing the mobilization. Here. My body going up and down. My arms are not doing this, they're just transferring that force into the upper neck. OA, non-thrust mobilization. AA, cervicogenic headache moneymaker, right? Remember the cervical flexion rotation test, this test, is what rules in cervicogenic headache. All the way up. Hold. Less than 32 degrees in either direction is 91% diagnostically accurate for cervicogenic headache. The way we treat that is AA thrust manipulation. We use the chin hold. The reason we use the chin hold, it's a rotatory thrust, and chin hold is just custom built for a rotatory thrust. The difference on the contact hand compared to mid-cervical, elbow is out. It's the lateral border of your index finger and your thumb, zygomatic arch, not jaw. So it looks like this. Contact hand. Your chin hold is middle and ring around the jaw, more importantly, forearm behind the ear. Okay, so we're here, like that. Top of her head, your deltopectoral region. Side bend. Side glide, a little bit of extension, rotate. Remember, the higher the arc of rotation, the better. If you're rotating that way, you lost your side bending somewhere. You need to be rotating on this new vector. AA. The non-thrust option for AA, if Rachel sits and faces the screen, I'm going to join you up there. You can grab C2, hands here, and just rotate C1 on a fixed C2. The way you make this work is you don't let your back elbow move, because that one's holding C2. And you simply rotate C1 on C2. That's a perfectly good way to normalize the afferentation, get rid of that asymmetrical signal, and stop the triggering of that cervicogenic headache through that trigeminal cervical nucleus. Moving down to the mid-cervical spine, we're back in this position. Now the contact hand comes in, anterior lateral aspect of my index finger. Mandible, elbow in. Like that. Other hand, cradle hold, up and above the ear. Not touching the ear, but covering the ear like that. Here. A little bit of side bending. Lunge, a little bit of side glide. Elbow goes out, and now we've got that Spider-Man kind of feeling here. And thrusting. The higher the thrust, the better the thrust. If you're going this way, you lost your side bending somewhere. Mid-cervical, multi-direction mobility, stiff patient, frank, right? On your left shoulder. Going to respond better to non-thrust mobilization. A quick stretch is not going to help legitimate mobility deficits. You've got to challenge that tissue and remodel it over time. Patient goes on their side. Why? So we can use our body. love the idea of a lateral glide, but don't love it in supine because my arms don't have that kind of power, my body does. Now I'm here, hypothenar contact, rests on the side of her face. My thumb falls just behind her transverse process. My other thumb goes next to it, and now my body can gently sink down, non-thrust mobilization, lateral glide. I think that is wonderful. C3 all the way down to the bottom of the neck. Lower cervical thrust. If you want to crack 5, 6, 7, you want to do it in the lateral flexion. The reason being, the facet joints are in a plane that are more frontal oriented. So at the end of the day, they're gonna like a lateral flexion thrust more so than a rotatory thrust. So now we get in this position, patient sinks down, their head needs to be below your xiphoid. Your hand contact is exactly the same as it would be for mid-cervical cradle hold. Thumb is on the jaw, anterior lateral aspect of my index finger is behind the neck. Other hand, fingers point straight down. Secondary lever, rotation. Secondary lever, lateral glide. Primary lever, lateral flexion. And then it's equal and opposite hands thrusting down. Pure lateral brake for the actual thrust. C5, 6, and 7 is probably best addressed with that. The junctional zone is also best addressed with a lateral flexion thrust, but more so in prone. So now the patient lays down and faces me on her belly. This goes underneath her right arm, which is down by her side. Perfect. You need to take off some of the rotation. You don't want your patient laying there in 80 degrees of rotation. That is way overuse of a secondary lever, right? So you want to build that up a little bit. I would say more than you expect, I think is a fair thing to say. So we're going to put this here, and we want Rachel on her nose. Put the side of her nose, not face straight down on the table. Hand in front of her ear, above her ear, fingers north. Here. Other hand, wider than you think. Everybody wants to drive into the neck. You want to be nice and wide out here. These two hands together, your body contact, railroad tracks with your forearms. They need to be parallel. Feel that lateral flexion, and then thrust. It's equal and opposite. Forearms parallel, front of the ear, wider than you expect. Prone cervicothoracic junction. I use this when people have neck pain. Human beings who have neck pain that are willing to be in this position, this is a go-to technique. Upper thoracic thrust, also extremely valuable. Patient goes on her back, slides all the way over to me. Far side arm is always on top when she hugs. The reason being you want to thrust into the joint, not into the open hand. Normally your patient's elbows are going to cross a little bit, which means that you need to roll up some towels and stick them in there so the humerus can't horizontally adduct aggressively and strain the back side of her shoulders. So we're here. Good. Your mass needs to be above the upper thoracic spine if you want to move the upper thoracic spine. Her shoulder should be right in between your legs. That would indicate your mass up by what you're trying to move. You can certainly start here, just make sure you step as you're getting the patient set up. Underneath her, it's a full fist. It's an adducted elbow, so your forearm runs medial of the medial scapular border. If you let your elbow wing out, you will thrust her shoulder blade into your forearm. Elbow is in. Then you step up. When you get over her, below your xiphoid. No, that is an unforgiving object. This is a relatively vulnerable exposed joint. Get the elbows in your belly. This will encourage use of hands. This will encourage use of body and allow you to steer. We strongly encourage you to go with this one. If you go here, you're going to push like that. If you go here, you're going to use your body. Put your forearm across her arms and use it as a steering wheel as opposed to getting locked up here. Moving up, full fist, elbow in, under the xiphoid. Okay, so we're here. there, and there. Feel that, and then drop down into it. Up, here, drop. It's your body dropping down and transferring the lowering of your mass into her upper thoracic spine. The mid-thoracic spine, we think is moved best with non-thrust mobilization. Sure, yeah. Okay, this area of the spine is one that is prone to very legitimate mobility deficits, which we think are best addressed by long doses of non-thrust mobilization. We don't tend to thrust this area. Number one, safety concerns, and number two, we don't think it's the right technique for that region in many cases. Arm across, she gives me a hug here. My pisiform is on my side of the spinous process, and again, I'm just lunging in to my left knee and shifting her weight to the opposite ischial tuberosity. I can get there and say, Rach, can you bring your left shoulder down towards your left hip and relax, sink into that a bit more, and you can do a lot of muscle energy techniques in this position. Better yet, if we have one more chair, someone not here. Better yet, because extension tends to be the vector that is desired, we want to get behind our patient if we can. So she'll rest her forehead on her forearms. I can now position myself behind the patient, and I can use my leg to draw her out into extension, and then use my body to sink down into her T-spine and create that extension all the way throughout in this region. She can again do muscle energy, trying to pull up, pulling out with me. All of those different tactics work really well in that region as well. And that's it. Good. All right. Grab your seats.